Castleman disease, which has been a large left to extrapolation to this point. Oh, that's true in adults, so it's probably true in kids. And Larissa's been starting to spearhead a project about how Castleman and pregnancy and fertility fit together, so we can tell patients stories with their fertility and how they made treatment decisions for the patients who were on chronic therapy and then later became pregnant or interested in conception, and how they managed dealing with the potential risks of treatment for their unborn child and dealing with disease management. So those are all some of the exciting things that I always can't not plug the registry, because that really comes from these patient summits and helping us to want to identify the topics we should be researching, and then also to get more people into the registry always, because that, I mean, you hear me saying it a lot, Larissa, about N is everything. The number of patients that we can put together, it helps us just tell a more powerful and nuanced story. It's only when there's too few patients that leaves us with, well, maybe I don't really know kind of answers. So this is about oligocentric Castleman disease. This is this entity that you can describe, or has been described, I guess, as a new diagnosis, but we know it's not a new diagnosis. It's just that
it's a new finding.
It's a new finding. It's something I would say that it's a story that we wanted to tell for a while, and only more recently with the Accelerate Registry have had the power to tell it. And it's otherwise been
10 years in the making.
I was good, yeah.
I showed up 10 years ago and said, I am not either one. And David said, I know, but I don't know what you are.
And this has been, the space between, right? Even in 2025, even with all the great work that this group has done and David has done, I still describe Castleman disease to patients as nothing more than big lymph nodes look certainly under the microscope as being the only thing truly unifying that puts everyone here together, whether they're unicentric or multicentric or oligocentric Castleman disease. Which is unsatisfying, right? It's both a huge step forward. Yeah, it's too broad. It's both a huge step forward and inherently unsatisfying because it's broad, and we can all, I mean, you don't have to talk to too many patients to see how many different stories and different responses and different treatments that they had to understand that we have a disease that we're under the monitor of that's quite broad, right? And involves a lot of probably different diseases that all ultimately end up with big lymph nodes that look a certain way under the microscope. It may have slightly different ways that they get there biologically. And what I think was while oligocentric disease was previously described in our what's that from 20? I have it here. In our 2020 in our 2020 diagnostic and consensus diagnostic and treatment criteria for unicentric disease, where it was relegated to its own section of that paper for those who care to use that one and then look down into the weeds of it. I think there were countless patients and physicians who were coming to us and David and saying, well, this is multicentric Castleman disease because 2 is more than 1, right? I count 2, so therefore it can't be uni anything, and so therefore it's multicentric Castleman disease. And I'm not sure if this is anyone's stories here, but we certainly have heard a number of stories of patients getting cytotoxic chemotherapy and other systemic treatments when they may or may not have actually needed that, largely because 2 is more than 1, and they didn't feel like they fit in under the unicentric banner, and so we're treated very similarly to how a multicentric Castleman disease would be treated. And I think this is part of the growing need for recognizing this as a distinct clinical entity, because it really didn't neatly fit into either of these diagnostic categories. Wasn't a single region of lymphadenopathy, but it certainly wasn't having the systemic inflammatory symptomatology at the severity that idiopathic multicentric Castleman disease had. And these are patients who didn't quite meet that diagnosis, even if 2 is greater than 1. And so, as I said, it went from this subsection of our unicentric Castleman disease consensus diagnostic and treatment criteria to now 2025 getting its own publication to more uniquely identify as a clinical entity. And that is where we're hoping will help patients and their providers to more clearly identify these patients and not start looking down multicentric Castleman disease treatment criteria, treatment guidelines that are not necessarily appropriate for oligocentric patients.
Tell you what it is, and they should do a trial on it.
Yeah. That comes
It's
next.
our next thing.
I agree. And we'll get to why, I think, during this talk.
Good.
And again, please feel free if we can be interactive here if there's anything I'm saying and you want to respond to and talk about, because we have a nice small group here.
I do have,
Please.
is there like an official way? So I was originally diagnosed with UCD because the 2 options existed. But it's pretty clear that I am not UCD. I'm straight off the bat, I had 13 lymph nodes removed from the first shot, and I still have more that we can't get to, and then my systemic symptoms. But my official like medical chart diagnosis is still UCD.
Yeah.
Do we have to do anything to change that, or does it matter if it's changed or not, or like?
I don't personally care too much about what's in the medical chart as long as your provider understands, who's treating you understands this.
It can matter
Yeah.
if you plan on trying to apply for disability or anything like that, because it's gonna make a difference in that. UCD is not, and I hope that gets worked on too.
Right, because we certainly
That some
know-
patients with oligocentric need the disability.
Yes.
So we need to work on getting that on that compassionate list with the multicentric.
Yeah. I was gonna say, does unicentric even have its own diagnostic code for it? I think it has to get, they'll just under cal, I have options for
Or is
multicentric
it just,
and straight Castleman.
I think it's just.
And so what I do is for
Right.
unicentric and I just use the Castleman disease,
Castleman
Okay.
disease?
as the like diagnostic billing code that is what they'll use for those sorts of things like.
There was a big argument when I was first diagnosed over whether I was UCD or MCD.
Yeah,
Dr. Naston David took me as MCD. Dr. Van Ryn was saying it was UCD.
yeah,
So, you know, even with the specialists like that, they had no idea really. No one was sure. So I'm not surprised that your doctor might be a little confused on giving you the correct diagnosis.
Yeah, and I like.
You should bring him
And-
some UCD
Well,
information.
I feel like an imposter because like I brought myself in here and I'm like, well, technically. I mean, I've also been to see Josh as my doctor, so
Sure.
I am
Sure.
Dr. Brandstadter is my doctor too, so I'm like, well. I'm not fake, but.
Don't feel like that. You have to advocate for yourself all the time. Never feel bad about something like that, Amanda. Always,
Yes.
always advocate for yourself, and don't be afraid to tell your doctor things or ask questions. You can't with this.
Oh, they're really great, and I am a very loud mouth. I just wasn't sure if it
Good.
mattered on my medical record one way or the other.
It mattered on mine for disability.
no. And just to be clear, like Castleman disease is a tricky diagnosis, right? I've already critiqued our own diagnosis, even if it's amazing improvement, it's still not enough. And so there are probably patients here who actually their definition of their disease might even be better suited by something else. I don't think that we need to take their shirt away and tell them they
Right.
can't come to the game.
Right,
For
right.
the summit or something like that. It's so hard
Take
to
their
see
shirt
from that
away.
angle, you know? They're welcome here still, I would say.
Yeah.
Because there, we can, just because clinically someone identify, they may actually be better treated under a different diagnosis and treatment. I still think they should be considered part of the community and not feel like they were delabeled on this disease that that they've been associating with, and that they lose their status in the Castleman community just because, oh, actually, maybe autoimmune lymphoproliferative syndrome might be a better fit for them. Still shouldn't feel like that they're not included here in any way, shape, or
And any of that stuff can be related to
because
cancer.
that's tough, because I think when you have a heterogeneous disease where there's a lot of different varieties of the disease, some patients are like, well, that's not my story. My Castleman is different than that. And as a clinician, I have to pause and say, yes, this is a disease where I know that there are a lot of differences with it, but I also want to make sure that is it different because of a reason,
Yeah,
right? Because it isn't.
Yeah.
But I can be also just socially complicated thing, because maybe that person was very active online with Castleman's and they see it as part of their identity, and I don't want to take that away from them.
yeah,
Even if I'm trying to find the right therapy, it's actually gonna make them better,
right,
right? And so always invited here, no matter what.
yeah.
Alright, so this is the sort of continuum of presentations that we've been calling a spectrum in the paper of Castleman disease presentations, from unicentric disease to multicentric disease, multicentric varieties of presentations, and oligocentric Castleman disease. And the idea of spectrum is to not or continuum is not to say that one brings the other. Your flavor of Castleman disease is your flavor of Castleman disease. A lot of patients with unicentric disease are quite terrified when they Google their disease, because they believe that they see the pictures of David in the ICU and everything like that, and they're like, that's my future unless we are
Think you're
able to right
dying.
this ship. And the truth is that's not what we see. We do not see unicentric or oligocentric progressing to become multicentric. And what the Castleman you get diagnosed with is the Castleman you have. And we're all putting on this under the umbrella of Castleman because big lymph nodes look a certain way in the lives.
How are we making out with there was a point where we were trying to get on the cancer registry and see if we could be, labeled as a cancer or something related to that, so that we could get in with the Cancer Society and everything. Is there any progress?
So what Dr. Noy has been leading with our group is she's been leading to make sure that Castleman disease management strategies get their own, and she's succeeded in doing this, get their own distinct section in the National Comprehensive Cancer Network's guidelines. Those are sort of like the oncologist's cheat sheet. One of the ways that we do to standardize clinical practice to make sure that it doesn't matter if you're at the University of Pennsylvania or other big fancy places, or at a community oncologist office in a very rural area that doesn't have all the same resources. We use these sort of guidelines that are created by, again, committees of expert clinicians, and then made into these basically fancy PDF files that are then broadly accessible.
10 years ago, you guys didn't do that, right?
That's exactly right. Well, we now have for Castleman disease, we have our published guidelines, which you're right, didn't exist preceding 2017, right? Then we also had these guidelines that were more broadly accessible to anyone who's generally a hematologist oncologist. They'll look to the NCCN guidelines. You used to have to look under lymphoma to find Castleman disease. And now that they're their own thing there, so it will help. So if someone just looks at Castleman, they don't have to think to look under lymphoma if they have their own. And that was what Dr. Noy had just recently pioneered. Still asking them to make changes, because there are ways in which their guidelines are not consistently hard.
It needs to be added to everything, because it's not added to a lot of stuff.
I agree. That would,
The Castleman website. I mean, I don't know what kind of push you have with that. The CDCN website, there is not a mention of oligocentric.
all right.
And if there is, it's the paperwork that it was, like from blood
Yeah.
and whatever. But the other two subtypes are
Are given,
laid out,
and oligo is not,
oligo is not,
we have to do that.
yeah. Yeah, I'm not letting us fall through the cracks,
please.
we started in the cracks, we're crawling our way out.
It's a little bit stressed today, but I
Yeah.
otherwise we should follow up with that.
Yeah, I will.
Not today.
Not
really
today.
I'll do it myself, I don't know how to, but I can learn.
I mean, I'm a computer programmer, so.
Well, there you
Yeah.
go.
These are good to bring up,
Yeah.
because sometimes these little things, like, we don't really realize, we look at, there's a website designer who may not realize those little things, like Madison probably isn't really in charge of that, someone else could pick up it.
But she'll know.
Yeah.
Well, yeah, exactly, so that's great.
Yeah, the
Bring up
website
that-
needs
bring up these
updated.
points, yeah.
Alright. So the definition of oligo, right, this is its own thing, you could sort of lead yourself into some of the subtleties of what we mean by oligo. A few, it's squishy, it's not just one area, but it's not everywhere, and so what do you mean by how many different areas can you have in the oligo? Where can those lymph nodes be enlarged and still call you oligo versus multicentric Castleman disease? And there's a spectrum, right? So there's going to be people who will say, I'm not actually fitting into your neat category that you made here. But generally, I think about oligocentric as being 2 to 4 regions of lymph node stations is what they're called, right? These are just different areas of lymph nodes. So you have multiple lymph nodes and still have it in one spot and still be a uni, actually, as long as it's one station. But you have different stations of enlarged lymph nodes, and they're generally fairly adjacent to each other. They're, usually sort of like patients who have cervical, axillary, supraclavicular lymph node enlargement. They generally, so this has been sort of like this dividing line that we borrow from Ann Arbor staging in the lymphoma literature. They're usually on the same side of the diaphragm. Crossing diaphragm, I think, should give us more pause about whether or not a patient has multicentric Castleman disease, even if it is only 2 to 4 stations. I think that should tip our head a little bit more toward thinking about multicentric disease for a patient. So generally on the same side of the diaphragm, generally, other like names that we have floated besides oligocentric would have been like regional Castleman disease, local.
That's how we
Castleman
started
disease.
talking about it, was regional.
Regional. And that's the idea, is that they should generally be fairly similarly located, even if they fall out of being in exactly one location. This paper, this is just showing you some of the flow chart that we use in mining the Castleman registry, the Accelerate registry, finding patients who were unicentric disease, multicentric disease, and then the patients who were in between. And you can just, again, point out, I'm just going to point with my fingers. You can see, these sort of in between were 14 patients compared to 46 with unicentric Castleman and 119 with idiopathic multicentric Castleman disease. Now, these numbers are biased, right? They're biased. They're always going to be biased toward idiopathic multicentric Castleman disease because it's the greatest generator of morbidity and mortality. So patients are always going to be more likely to want to get involved in their disease, to come to summits, to join registries because of that. So that there's going to be that bias. And obviously, of course, where we're coming from with David, there's that sort of bias toward multicentric Castleman disease. So we're always going to be better at getting those patients into registries, but we're getting there, right? So I think we have to take that number 14 as being both a cautionary tale about our explanatory power, right? But then also say that we're look at the progress that we're making toward better defining this patient population in between. So you take all these patients and then you actually plot the number of enlarged lymph node stations that's on the x-axis here. I think those numbers are quite small, 1 all the way up to 16 here. The number of minor diagnostic criteria, and that would be things like anemia, thrombocytopenia, low albumin laboratory findings, like that, or kidney injury. And then other minor criteria in terms of symptoms, drenching night sweats, losing, weight loss, rash, and you can see the IMCD patients in green are all these green dots, many different lymph node stations, many different diagnostic criteria in terms of symptoms and laboratory evidence of systemic inflammatory disease. The unicentric patients are all the way down here. I mean, by definition, they should all be about where the 1 is down here for lymph node. And then some of them do have inflammatory labs or symptoms as well, stretching them up here. And then we put in this other group that we're calling oligocentric down here in purple, where there's more than one lymph node station involved, but generally not as many lymph node stations or as many inflammatory signs and symptoms as the multicentric Castleman disease patients. And then you can see where these lymph nodes are by there's sort of these little red dots, and you can see generally they're all in fairly similar locations, without crossing the diaphragm for the patients, what we were defining as oligocentric Castleman disease. We can look at where our Castleman disease panels, that's one of the powerful thing about a registry, right? Besides the fact that we're connected with you guys to help us make this possible, to get enough people together to say anything. The second, I think, most powerful thing about our registry is that we have this expert group of clinicians, pathologists, and clinical doctors like myself who weigh in on every diagnosis because it's so tricky. So they actually look at the slide and say, yep, those are the Castleman features there. And that will help to deal with the heterogeneity, right? So we can try to get a little bit more finesse of exactly that these are, when we say Castleman, we mean this is what they have, right? These sort of features. And so we can see that of the patients that our panel thought had idiopathic multicentric Castleman disease, most of their doctors also thought they had multicentric Castleman disease. Some of them thought that they had unicentric Castleman disease. And then for the patients who we thought had unicentric Castleman disease, mostly the care team, the doctors actually taking care of that patient, still also thought they had unicentric Castleman disease, these being like the sort of error rate that we would call for the local team. And then for the patients who had oligocentric, most of their providers thought that they had unicentric Castleman disease. And but a significant minority, I would say, at least about a third, thought that they actually had multicentric Castleman disease. We take the patients that we've defined as multicentric, unicentric, and oligocentric when we ask about their symptoms that they feel. And you can see that the symptom burden for the oligocentric Castleman disease patients is generally fairly similar to the symptom burden borne by unicentric Castleman disease patients, which I think fits with almost everyone's clinical
I
story.
don't know if I agree with that.
Okay,
I don't agree with that.
please.
I think there are more symptoms in oligocentric,
Compared to-
sure, compared to UVD and closer to the IMCD, at least in my experience.
I agree with you on that. I would say that I don't think we have the power to make those sort of, I agree with you. I think it should like,
It should be.
I would probably draw that line there, right, in between.
Yeah,
But I don't think there's any way that with the numbers that we had of putting that line exactly where it needs to
Right.
be.
right, we only.
So the message that I like here though is that it is something less, which is part of by definition here, is something less than what the multicentric Castleman disease patients have.
Yes.
Or not having patients going into with oligocentric going into the ICU. Generally, they avoid being hospitalized as well, I would say, for the most part. But that doesn't mean that that doesn't make it asymptomatic or a
Right.
cakewalk just because our standard would be admission to an ICU or hospitalization, right? Still significant symptom burden, but something less than what they are multicentric, and there's some similarity to unicentric in terms of the clinical presentation and symptom burden. Although I would agree, I think it's generally a little bit more. The lab abnormalities also, again, this is sort of by how we're defining this, also generally fit. You see lower albumin levels, higher creatinine levels, higher CR reactive proteins for the multicentric calcium disease patients. And it will be more similar for unicentric and oligocentric calcium disease. There could be differences that we're not detecting. But that just is, I would say, limited by our explanatory power with the numbers. So it's clear that multicentric has worse laboratory abnormalities, but the unicentric and oligocentric have generally comparable laboratory abnormalities. We can look at 3 other different measures: hemoglobin, immunoglobulin, and platelet numbers. And again, we see more laboratory derangements with multicentric, and generally similar amounts of these lab abnormalities between the unicentric and oligocentric calcium disease patients. This is where we started. This is one of the first things when you sat down, which was about treatments. And with 14 patients, we don't really have a lot that we can say cleanly about treatment. You can see the way some of these patients who we had in our registry were treated and their responses. And I don't think there's any clean story here about a particular treatment that was the winner, was the best way of treating them, right?
Yeah. Yeah, I went through a bunch of treatments.
Yeah. And
before we got to the one you suggested.
yeah, and I don't know if we're going, and I don't think right now anyway, we're in the near future, we're gonna have that's the one, we gotta do that one. It's not as clean as we have with the multicentric calcium disease, where we have a phase 2 clinical trial clearly showing a benefit to siltuximab. It works in a third to half of patients, depending on exactly which data you're looking at and how you parse it out. And so it's a clear, we should try that first, but I don't think we have that for oligocentric
I
calcium
did the
disease.
rituximab twice. I did the Rituxan Hycella. I
Yep.
did siltuximab. And then I was back to rituximab.
Yeah.
And that's where we hit off to the obinutuzumab.
Exactly. Does anyone else, and I don't want to put anyone on the spot, but does anyone else want to talk about their treatment stories, or? Well, you don't have to.
It's like I don't I have a lot of so many questions are going through. my head.
Second.
So my situation is similar. Penny and I have talked in the past. My situation is similar to Penny's. In my diagnosis was so long ago, and there was stuff removed before anyone was even testing for anything.
Yeah.
We were 20 plus years in, I think. And it wasn't at Penn. I'm at Penn now. But so I don't know if originally it's for insurance purposes or whatever, but like what my paperwork says, possibly versus what I'm gonna accelerate as.
Yeah.
I don't know, I wouldn't know that they match because we don't know that data, like those 14 people, if they had names next to them, am I in those 14? I don't know.
Yeah.
You know what I mean?
I'll say they're ethically bound not to tell you.
No, I can't understand, and then that's why things are going through my head, like the 14 people that are in there, my question, are
That
they?
becomes an active clinical trial where we're all making treatment changes or something like that. Yeah, no, I want to make that clear, yeah.
But the 14 people, are they all in the US? Are they all like, and the 14
That's a
people,
good question, I'm
like,
not
are the 14 people
sure.
all being treated at Penn? Are the 14 people, and 14 people is such a small number.
Yes, it is.
It's like one of them, you know?
Yeah, no, I know.
Like that's the thing, like I know what my paperwork says and I know which drugs I've been through and how it's been treated, and I was one of those people who was initially diagnosed with non-Hodgkin's incorrectly.
Oh my
And
gosh.
it was at Hopkins in Maryland. And my clinician, wonderful, great guy, presented my case at ASH. My onset was weight loss, catastrophic night sweats, and a 10 centimeter axillary node
Yeah,
that I thought was a cloud milk duct for breastfeeding. I thought the weight loss was because I just got rid of that baby weight, like I thought everything, until it turned into 60, 70,
Yeah.
80 pounds, and I was 83
Oh,
pounds.
jeez.
You know what I mean? I'm double 83 pounds now, but you know what I mean? So I thought it was all kinds of things going on. You know, I was going through a divorce, so the weight loss is like, you know, that's the divorce diet.
Yeah.
So all of it, but I was literally a day away from starting RCHOP. And my doctor at Hopkins called Fritz and was like, hey, can you take a look at this? And he's like, send that lymph node to Elaine Jaffe.
yeah,
And she was like, no, this is Castleman's, and give her this and she'll get better. So I did rituximab, like I think I did 6 weeks in a row, like back,
Yeah.
whatever, this is 100 years ago, 101 years ago. Didn't initially get better. So Dr. Van Rees said, you know, looking at her scans, her spleen, take the spleen out, because that was like, we don't know enough yet, take the spleen out. It was like 3 times the size it should be, take the spleen out. Take this out while you're in there, take these other lymph nodes out while you're in there.
Yeah.
But there had been so many other surgeries in my life prior to the Castleman's diagnosis that things that were taken out weren't studied for that, if that makes sense.
Yeah.
So the things that like you guys do have, or you know, think you have, are the things they were able to get post my diagnosis in Baltimore.
Right.
So different hospitals there, Hopkins and IH. But I've been getting rituximab. Sunita says I'm her data-free zone. But now I don't think it's so data-free because it's been 7 years. So for 7 years I did we did 8 in a row and then switched to every 8 weeks. It's helped a lot with symptoms, with like getting sick and then just going from, you know, 0 to 100. Like I could feel sick and then all of a sudden I'm in the ICU. All of a sudden, you know, it's like, and this not having the spleen doesn't help that.
Yeah.
You know, pneumonia, strep, you know, germy kids and
Yes,
you know,
of course.
all that kind of stuff. So you know, keeping the rituximab as a maintenance kind of thing and just saying settle the heck down so my immune system has really helped. I mean, symptoms come and go still, fevers, night sweats. And she always says, she's like, you know, like in my clinical notes, it's like her IMC day, and then it's like, but initially they said UCD, but she's just like, you know, ever since I started with her coming up with 10 years ago, she's been using Oligocentric, like with me
Yeah.
in conversation, but it's just, I didn't realize the number was still so small.
Yeah.
And I was just curious as to if being in that group of 14 is something that the castle decided, or did your doctor send notes that say, this person is
No.
actually Oligocentric?
So this 14 is purely for research purposes. Because that's the whole point of Accelerate Registry is to help us to adjudicate things so that we can have as clear an idea of what Castleman disease is. It's not that someone's Castleman disease because a local provider made a horrible mistake or something like
I
that.
wasn't trying
Oh, yeah,
to say anything bad about the
Okay.
provider.
No,
I
I'm
was
saying.
just curious as to if those 14,
I-
like the 14 that you have in your group, are they in your group because you looked at their
Yes,
chart and said, I don't believe this is this, and you put them in that 14?
yes.
Or did their doctor say, hey, here's someone for your study?
Yeah,
Sure.
those 14
Yeah.
all went through the CAS as being Castleman disease,
Gotcha.
unspecified or
Gotcha, okay,
the finance
okay.
word we use, meaning not
Gotcha.
clearly unicentric, not clearly
Right.
multicentric.
Got it.
And so that's why we've had these patients
And there's still only 14.
sitting in our registry for a while, and now we're giving them their own.
That's why we were
Come on.
falling through the cracks, because there's not so many of us.
Yeah,
Yeah. Yeah. And I don't even know if I have one. So, you know,
Are you seeing Dr. Nasty? Do you
Yeah.
mind me asking?
Yeah, oh yeah, yeah, yeah. That's
She's already mentioned Oligocentric.
Oh, she's
Yeah.
been mentioning
Oh.
it since before anyone was mentioning it, but
Yeah.
if you log into my pen chart or look at my insurance paperwork, it says IMC day.
Yeah.
You know
Yeah,
what I
mine
mean?
does too.
Yeah, so.
Mine does too, because we don't have a code for Oligo.
oh, yeah.
Right, right. I just don't get what it's such a large number. Just because she's been saying it for 10 years to
Yeah.
me, and I'm like, how's she pronouncing that word? You know, I'm like, what?
That's right.
Yeah, well, thank you so
Of
much to
course,
everyone
yeah.
in this room, really, and thank you to you.
Oh, God, I was not letting us go down without a fight.
Josh, what made you
It's just
decide
funny.
trying that benitumab for her? Like, what was what came to you that said, hey, let's try?
Oh, to use obinutuzumab,
Yeah.
I would say that, I don't
I
remember,
was
I
starting,
think you were having
I
like,
was timing out on the rituximab.
you were also having some benefit.
I was still having
It
some
wasn't enough.
benefit, but I was still having
Remember-
symptoms and everything.
Rituximab is a 30-year plus old medication from the 1990s that
And it
worked.
times out.
Yeah, that was also one of the, I would say it was one of the, founders of the class of medications of monoclonal antibiotics, right? This was, if you picked up a Scientific American in the 1990s, they were talking about how there were magic bullets that were discovered that could target cancer cells. And this was what they were talking about, was Rituxan. Works, right, by identifying B cells through the molecule CD20 that's expressed on the surface of B cells. These are the white blood cells that live in the lymph nodes and are mostly what is in a lymph node. That's the bulk of the cell. About 85% of all the cells in the lymph node are B cells. And so it tells the rest of the immune system to get rid of it. We know, I would say, to the extent that there is any disease-causing tissue in Castleman disease, it is the lymph node. And so that was the reason for using Rituxan in Castleman disease patients, and it's also cribbing from the lymphoma literature, which is where it's best, known to be used now. Rituxan and all of its ilk were used pretty broadly across different autoimmune diseases as well, because B cells don't just become cancerous and become lymphoma, they do a lot of other they can be bad actors in a lot of other different diseases. And what's happened is because of some degree of efficacy of Rituxan and because of side effects that patients can have with Rituxan, it's part mouse, that protein. It was the part that binds to CD20 is actually still a mouse protein that they use, and so the allergic reactions can be
That
common.
explains
With
these.
Rituxan, they developed the second generation CD20. So they work almost the basis on how they work is the same for all the obinutuzumab and the ocrelizumab and the other
The maps.
the mAb. Well, there are lots of mAb just means monoclonal antibody, but all these other CD20 targeting treatments all work exactly the same. But these new second generations, there is evidence that they work a little bit better in terms of their degree of getting rid of B cells. And they also can be better tolerated for patients who do have severe infusion reactions with Rituxan. And so that would have been my thought process for you, is maybe you were just you showing us that your disease is very sensitive to CD20, to getting rid of B cells, and we just need to do a better job of that.
No, you've been a child, is doing it.
And so that's
The quality of life going up for sure.
because that's for me the thought process of thinking about that medication in general. For patients who show some degree of benefit with Rituxan, and it's just not enough, I think that makes an obvious next step for there. And I think that's a lot of what we're looking at the Castleman disease. For Castleman disease, we're looking at, we've written this whole wave of immunologically active medications that have been developed for the purposes of anti-cancer treatments and autoimmune disease literature. And this is a learning beast, since we're not going to have the luxury always of having clinical trials to help guide our management using that level of evidence, which is what Dr. Nassif said. I'm in the data-free zone. It's like that's the whole point of seeing a doctor, right? We're not selling our tonics and elixirs anymore. We're supposed to be telling you, look, I did a large-scale clinical trial. I had 1,000 patients in one arm, 1,000 patients in the other arm. Arm B, you did better, and that's why I can feel confident telling you it was arm B. But if I'm talking about these smaller groups of patients, I'm not going to be able to get that level of evidence for you. And even that group of patients that I do have assembled are all sort of different from each other. I put them under the umbrella because I can't do any better at teasing them apart and providing a very specific biology answer for why they have their disease, right? You're going to have trouble saying this is the winner for you. So that's why I think drug repurposing is going to be is super important for patients with oligocentric Castleman and Castleman disease who don't respond to siltuximab, as well, is because there's differences between them and getting that level of evidence that we really want, that should be our gold standard, and it still is our goal always, right? But we have to tolerate that's gonna be slow getting us there. And that's gonna be the name of the game for us, right? And finding therapies that could work. The nice thing also about the CD20s, I would say, is that there's, I've told you, Rituximab's story goes to the 90s. We have a very long history of safety and tolerability of the medications. We know what to expect with it. And so that helps us as well feel better about using them, right? And because every patient, it's a risk benefit decision, right? And if I don't have a very high level of evidence, if I don't have a large scale clinical trial, it's also a conversation, right? With the patient about what they are willing to accept in terms of potential side effects, treatment versus their symptom burden from their disease, right? And so that's sort of how we make these decisions together with the best evidence that we possibly can, knowing eyes wide that it's not where it needs to be, right? With that and minding the time, I'll just say that the consensus guidelines for treatment for oligocentric calcium still is coming from this 2020 unicentric paper. Whereas we're thinking that if it's possible, if the surgery is not too morbid to do, try to cut out the enlarged lymph nodes, because with the idea that could be potentially curative. That doesn't make sense for everyone, right? That could be like, oh my gosh, you're really gonna be playing some horrible game of operation on me, and I'm gonna be subjected to to a disfigurement. So that's out, right? Because we don't know it's going to be curative. But if it's feasible to do, we're only talking about maybe a couple areas, and we're talking about a couple of different large lymph nodes. These surgeries are not like typical cancer dissection surgeries where we think about taking every lymph node in the area out with high risks for lymphedema. We would just focus on the large lymph nodes. We can think about this as being a potentially curative route, so that's why it's still recommended for oligocentric patients, with the idea that, again, differences, not every patient is the same, and thinking about what that surgery looks like for someone in reality. And so I always try to, let's work with a surgeon at some point so they can know, at least hear the story about what it would take to get those lymph nodes out. And then sort of we can then decide whether that actually makes sense for the individual patient. Again, so resectability will still be what the first line therapy will be. And then we have the same, this is a treatment paradigm that if anyone was in my UCD talks, I'm just cribbing here. So it's not necessarily, it is extrapolated sort of things from the unicentric about thinking about different modalities of therapy that can be used for oligocentric Castleman disease patients, either to make someone surgically resectable or to think about treating its systemic inflammatory symptoms, again, looking toward repurposing from the IMCD literature.
I'm sorry, what was that last?
Please. Yeah.
The side effects, okay,
Yeah.
sorry.
Oh, yeah, absolutely.
We also have 2 questions.
Oh.
We can also get to those at the end, but depending on how you.
Gotcha. I have till 12:15.
Yeah.
Is that right? Okay, so let's do the questions from the Zoom.
Okay, great. So the first question is, one big mediastinal mass and 4 little cervical lymph nodes, is it oligocentric?
Yeah, good question. I would say first, it would be important that the way we defined it to not, although the patient, I would presume otherwise would not meet the minor criteria for IMCD would be important. I also do think sort of like these bigger masses are usually more of like a unicentric phenotype. They usually have that, so like multicentric patients generally, and not always, generally have smaller lymph nodes than the unicentric patients do. I think it would be fair to think about that patient first from a unicentric perspective, because there are situations where you have one really dominant mass and then some smaller masses. Some smaller, like they're pathologically enlarged in cervical lymph nodes, right? The radiologist said they were enlarged. But I have seen situations where, particularly for patients who have like one really big mass, you resect that one big mass and the other ones regress. And this is something that I've also, and I think I've told you this story, Larissa, I've learned from the research end of things, whereby there are several different enlarged lymph nodes and they all get resected, but their actual histology could look different. So some of them actually you can see Castleman changes in some of those big lymph nodes, and the lymph node that was right next to it that was too big doesn't have those Castleman changes. It has a more like generally reactive look under the microscope. And so this bothered me from a research standpoint because this was the very first time I got a lymph node from a patient to try to understand what was, to try to study it. And I'm like, well, which lymph node did I get? Did I get the Castleman one or the inflammation one? This is what led me to make sure we took a piece of every lymph node we got to confirm that diagnosis in our patients. So I would say probably without knowing any details, with the idea that I should not give very detailed medical advice for a patient I do not really know beyond that question. But I do think with that general framing is that thinking about unicentric may be helpful. And then see over time, assuming this patient has the benefit of that, to see whether these other lymph nodes don't just regress on their own before thinking about looking at patients more oligocentric. Okay.
And then
Next question.
the other question was, does siltuximab shrink lymph nodes?
Does siltuximab shrink lymph nodes? A little bit. Generally, it's not the bigger. It generally does not shrink lymph nodes to the same degree that Rituxan might do, because Rituxan is getting rid of the major cell that constitutes the bulk of what's in a lymph node. But siltuximab does shrink lymph nodes. We certainly know this from idiopathic multicentric calcium disease patients. You see patients who have wonderful responses to their therapy and their lymph nodes will shrink. Not all of their lymph nodes do shrink. So you have patients who are wonderful responders to siltuximab who still have pathologically enlarged lymph nodes. But they're living their lives, they're okay, their symptoms are taken care of, their labs are fine. So I always say for siltuximab responding patients is to not be like a slave to the PET. Don't think that it's the harbinger of badness to come or some degree of refractoriness just because the PET doesn't look perfect for patients who are otherwise clinically and laboratory responding to siltuximab. So it does shrink a little bit, but not necessarily to the same degree rituximab does. Cool. I did just throw in some of my own research that I've been doing here, where I'm focusing on other cells that are in the lymph node that are not white blood cells. This is really small fraction. This is like less than 5% of what's in a lymph node. There are these structural cells that help divide up different rooms of the lymph node. We thought about them as being boring fibroblasts. They're just the walls. They're the glue of it all. Who cares about it? But I think there's been a pretty increasing body of literature from basic science that these cells are not just inert walls. They actually talk to the white blood cells and they have a sort of air traffic control role in telling white blood cells where to go, when to get activated, how to activate. And I've been studying their role in Castleman disease because we know some of these, what we do have for defining Castleman disease, these histologic changes, the way it looks under the microscope, involved changes to these stromal structural cells. And I've been using fancy techniques, taking lymph nodes to define these different kinds of structural cells. And I've been finding that there are specific changes. This is looking at unicentric Castleman disease in the composition of the stromal cells in Castleman compared to otherwise big inflamed lymph nodes that someone thought might be Castleman, but are definitely not Castleman, that we can see is unique for our Castleman patients. And then when you have patients who are somewhere in between, the pathologists disagree, and it's all unclear. Or what's my favorite diagnosis is reactive with Castleman-like changes.
Oh.
What do I do with that, right? You take some of those patients and you can see a subset of them actually have the same sort of stromal structural cell compositions that are just like Castleman disease patients. We can then try to simplify that since no one's doing the fancy science techniques that I did in terms of the clinical practice and look at that as just simple stain for one of these kinds of structural cells using this antibody called MCAM that can help us to identify in brown and green these kinds of particular kind of structural cell that seems to be increased specifically in Castleman disease. And we can see it does seem to be increased in lymph nodes of Castleman disease patients, particularly unicentric Castleman disease patients, even compared to other disease causes of enlarged lymph nodes that can sometimes get confused with Castleman disease. So I'm trying to help us with this diagnostic problem that has been plaguing our community for so long, which is, how do I get a diagnosis, particularly without being connected to a big fancy place that happens to see tons of Castleman disease. There's a way my doctor and my pathologist close to home can make a diagnosis. And so that's what I've been trying to do is use advanced techniques that can then be simplified into just doing something simple, like one antibody. That's all another thing with a blood test, right? And that's another thing project that we have going on in our group is do a blood test to help more specifically diagnose patients with Castleman disease.
I don't want to interrupt, but after her third surgery, the lymph node was finally sent to Florida, I think it was.
Yeah.
And the pathologist down there
Knew
was
what it
saying,
was.
wait a minute, this could be this Castleman disease. And
Yeah,
before that, they thought she might have lymphoma. They really weren't sure. They had no idea.
yeah, this
The
is a big problem,
The
right?
first two surgeries, they just just came back as reactive.
Yeah, reactive.
And that was it.
I
And after
think,
the third surgery, it was finally, the guy up here said, I don't know what this is, or something that I really don't know. Let me send it down to a friend of mine down in Florida, and he was the one that said this looks like it's Castleman's disease.
Yeah,
I think
Look
you're
at that
born
one.
with it. Personally, I
Yeah.
think you're born with it.
Yeah.
And I think that it just chooses its time to become active. Because now I heard your story about how you had problems with your health and had multiple surgeries and everything. I had the same type of story with my health, and it started when I was young.
yeah,
And I was always sick, and I always got sicker than everybody else, and it always lasted longer than everybody else. They just knew when I was sick, I was down.
It's not gonna be the
So-
importance of the blood test.
yeah.
I really think that you're born with it, and I know we don't have all the, everything for that yet.
Oh,
But
yeah.
I feel like you're born with it, and it could have been haunting you for years before it reared its
Yes,
ugly
I get
head.
like ideas in my head, like, where was the tonsillectomy at 30, the start of it, like was it like, cause my lymph nodes were catastrophic at that point, and they were like, you need a tonsillectomy, I'm like, I'm 30, and tonsillectomy is like scarier than childbirth at that. You know what I mean? 'Cause
It's a painful
I
surgery.
know it was
We
horrible.
dismiss it for kids. Eat some ice cream, you're fine.
Yeah,
But it's a painful surgery.
yeah, it was rough, but then you start to go back to things like you're saying, if it was there forever, I did have like serious illnesses as a kid that everyone was like, oh no, you got that from this person, or like we had a group of people around here pass away from meningitis. And I was in shock for a month. And I was sicker than everybody else. I somehow pulled through it. Some other kids in our group, like it was a basketball camp.
Did you actually have meningitis?
Yeah, like spinal tap said, yes,
Okay,
bacterial meningitis.
Because they
And-
tested me for that at one point too, that's why
Yeah.
I asked. I had
Um,
pneumonia really bad, but they ended up doing the spinal tap because they thought it was meningitis.
I've had several times later in life where I've been so sick that they thought meningitis. So like, just no more spinal taps, please.
Yeah.
But where they've done it just to rule it out. But that, like, when you go back to the history of having something that you feel like nobody else had, like having meningitis at the time I had it, kids at basketball camp in the Poconos got it, passed away at camp, and then I had it 2 weeks later. And was in shock for like missed my whole junior year of high school, just from side effects from being that sick for that long. So it's kind of weird, like what, were our immune systems weak in our teens or? I don't know,
Yeah.
you know, like my immune system sucks now, but I also have gone 25 years without spleens. That's why I have one doctor. Can I ask this? Do you just have Dr. Asta? Like, do you just have one?
Well, I have the team here at Penn,
Gotcha.
so do you.
But I mean, I don't go to, like, if
I see Alicia.
no, I mean, if I get a cold, I don't go to urgent care, you know what I mean? Or I would never walk
I
into a
let her
hospital.
know right away.
Yeah, I do the same, yeah.
And my primary is fabulous at keeping everything together. And if I call my primary and tell him I think I need something, he pretty much jumps.
Okay. Yeah, I don't have a primary anymore because she, like, specifically was like, this is just. Didn't know enough about Castleman's, and also my blood work is so crazy without the spleen. Like if I walk into an emergency room, they see my white cells are always elevated
Yeah.
without your spleen, and my platelets are always high.
Yeah.
So it's like they look at it and they're like, what's wrong with this girl? And it doesn't show up like, hey, Castleman's people should have high white cells and high
Right.
platelets all the time, because that's because of the splenectomy, not because of Castleman.
Yeah.
Amanda, were you sick as a child? Do you mind me asking? Have you been sick for a long time before Castleman's came?
No, I mean, I had a lot of ear infections, but then I was fine. And then I had a lot of headaches that they couldn't explain, but we chalked them up to, I played rugby in college and I had a lot of concussions, so it made sense.
Maybe.
But my current rabbit hole of like maybe what's related, what's not, is I had a lot of fertility problems.
Me too.
I had a lot of miscarriages.
I did too.
That came back where all the testing was perfect, tests look perfect, you look great, everything's great, everything, no pauses. And I recently have started just having pulmonary embolisms for fun. And now when all of the clotting blood work came back clear, no causes, no nothing. And I sent this panicked email to Josh in February, and I was like, "Is there any research?" It's like I'm trying not to die.
Yeah, it's scary when you get
Because
stuff.
all the fertility blood work had come back. That's one of the things they test for is clotting and whatever.
Yeah.
And then they ran it after my first pulmonary embolism, which was 2 years ago, and then I had another one in February, and but now I'm like, well, if my immune system is just overactive. And I've always had a lot of like period problems, and things that I've been diagnosed with only in the last 5 years. But like PCOS, endometriosis, adenomyosis, all of these things. And I don't know, like chicken or the egg, who knows what.
I also had a lot of problems, female problems. I had a hysterectomy at 14, a partial hysterectomy. They left me a quarter of an ovary and one tube, and somehow I miraculously got pregnant. And that was a problem pregnancy, but you know, we lived through it. And after I had her, I got pregnant again and miscarried, and that was it. I had a hysterectomy, that was the end of me.
Yeah, I had a hysterectomy 2 years ago. Then my ovary exploded in September. So I had that emergency surgery. But I have a lot of weird body things that just keep happening. So not on any treatment because my blood work is perfect. But all of these weird things keep happening, and so all of my doctors are just like, well, I don't fucking know.
I think there's a t-shirt for that.
Yeah.
That's come back.
Yeah. And I'm like,
Why not? We can make one.
yeah. And I'm like, so I don't know. But yeah, I was not like, I had a lot of ear infections and things. And then my migraines started really bad, but they started really bad after I had a really bad concussion. So it was not, I don't think
It's interesting that we've all had the female problems, and
Yeah.
that's been brought up before.
yeah. Well, and I asked that I got diagnosed in 2020, and I asked that question about miscarriages, and they're like, well, we don't really know, no one. And And then I had, when they brought up the study last year, I had said, you know, hey, I'm never gonna be pregnant again, I don't have a uterus, but I have a emotional support spreadsheet, because that's how my brain works, and I have like every test result for the past 10-15 years.
It's great.
And so I was like, I have this, and then I
Here
requested,
you go.
and I requested my fertility clinic documents. And that's a mess. It is like just a bunch of scanned file, like scanned paperwork. It's like, I know they have them digitally, but it is a bunch of scanned pieces of paper in a PDF. And I was like, my dudes, you have medical records. But so I was like, here you go. Yeah, but now I'm pulmonary embolism for
They're scary.
no reason.
They're scary.
And then like weird other things, like all of a sudden all my tattoos will become raised. And like I'm having like an allergic reaction to my tattoos that I've had for years. And I'm like, just like weird body things. And I'm just like, I don't know, it's probably fine.
You're just reacting. I'm
It's
just reacting.
it's fine.
Like when someone writes Castleman's related rash in your chart in the emergency room. Do you even know what Castleman's is?
I had a foot doctor's, I had a podiatrist and her PA. PA started asking me questions and she started to ask me my medical history and I said Castleman's disease. She said, I'm so sorry. And I'm looking at her like, you don't know what the hell Castleman's disease is. You're a PA for a podiatrist. I'm like, tell me you heard about Castleman's disease. And then the podiatrist came home.
Get out there more.
And then the podiatrist came in and acted like she knew it. Yeah, but when I questioned them, they had no idea what I was talking
I went
about.
to the eye doctor because I have binocular vision disorder, so like my eyes are slightly misaligned, so I need prism lenses. And I went to a new doctor and they had like a form like this and it was like your 10-year medical history. So I filled out everything because I was like, I don't know what you're wrong there. And then the intake person was like, well, I don't know if the glasses are gonna help with your infertility, like your miscarriages. And I was like, really?
You're kidding.
I don't think that they are. I was like, I don't know what kind of. I was like, I don't know what kind of magical glasses you thought I was asking, but I was like, you asked for my 10-year medical.
Or she's doing something different than you are. It's an eye exam. It's gonna help infertility.
The best was when advanced radiology for my PET scan. That's when my last period was, and I said I had a hysterectomy, and she said, right, but that doesn't prove you're not pregnant. And I was like, oh my god, I don't know what to tell you. I don't know what to tell you about that one. And then I gave her the date, and she's like, well, that's over 2 years ago. And I was like, it still doesn't prove I'm not pregnant if that's what you're going for.
I just say 1982. 1982.
Oh yeah, she's like, that does. I was like, I don't tell you. I don't know what to tell you then. I was like, I'll sign the waiver for the PET scan.
Thank you so
It was
much.
lovely talking with that Brandstadter.
It was fun. It was good to see you too.
It's very good.
Keep up the good work.
I'll try not to panic emailing you in the middle of the night.
It's okay.
I sent a deranged email. I to Josh, David, Madison, Maleva, I think, and I was like, guys, second PE in 2 years, and is there any like all the tests are coming back? They don't know what to do with me, and I just don't know. I'm trying not to surprise die.
Don't be.
Is there any? I was like, is there any research with any possible correlation?
We have patients with IMCD that have thrombosis.
Oh, for sure. Oh,
Well, that's I was like
Very
with
common.
I was like with UCD or with OCD. I was like,
that's less common.
yeah,
right?
but I was like, I don't know what to do. I was like, I'm just trying not to surprise die.
Yeah,
Yeah.
coagulation.
I hate getting sick. Especially with COVID. It scared the hell out of me last time I was passing out.
Yeah.
And I, it
I
was
actually COVID was I've only had it once,
4 times.
and it was great compared to the shots. I had a violent reaction to every shot, like put me out, projectile vomiting, cold sweats, horrible headaches for days at a time. But then when I got COVID, it's like minor sinus infection. I was like, yay, guys. Oh, yay.
Oh my goodness.
I'm good.
Thanks, everyone.
Thank
And
you.
you can continue the conversations in the next session.
Which is
Session.
Let's
We should
lunchtime
lock it
now,
down,
right?
right? Now it's lunchtime, please eat.
Thank you, everyone.
Thank you.
Thanks, Josh.
Yes.
Absolutely.
Thank you. And
I'm
for us, everything you guys arranged.
Day, but I might not get a